Joe, ladies and gentlemen, first of all, I want to thank the course directors for the invitation. It's a great pleasure and honor for me to be part of this distinguished faculty, especially since I left Mount Sinai 11 years ago. Before that, I was there in Dr. Grieb's animal lab. When I got the invitation and the title, I started an internet research at the beginning. Oh, that's the wrong one, sorry. Started internet research at the beginning. And it was not really unexpected that I learned a lot about animal physiology, about proboscis and trunks. And you probably all know that the proboscis is an elongated appendage, and it is for feeding or sucking, and sometimes it's just an elongated nose or snout. But you probably don't know that the proboscis is also a fusion of the nose and the upper lip. And you can distinguish between an Asian and an African elephant not only by the size of the ears, but also by the end of his trunk. So you see on the left side, there's an Asian elephant with a single finger, and there is an African on the right side with a two-finger-like projection. So in this species, there are differences in the elephant, in the trunk, but there are also similarities between two species, as you can see here in this picture. I don't know actually what Hans Borst had in mind when he invented the elephant trunk technique. It was definitely, I think, a technical revolution in 1983. And he faced at that time, as many of you did, extensive aortic aneurysms with complex pathologies, as you can see here, with a huge aneurysm of the ascending and descending aorta, or with a rupture, what you can see here, or a dissection on this side. So we are all aware that aortic surgery is associated with significant morbidity and mortality. And if you plan an operation in this situation, you have to think about some extra points. Here's the myocardial protection first. Second, the protection of the brain. You heard a lot from Dr. Grieb and Dr. Spielvogel. I personally agree that selective antegrade cerebral perfusion is the best way to protect the brain. But you also have to avoid end organ failure, and this is especially true for the kidney and the liver and the bowel. You have to think about respiratory compromise, because it can happen, especially if you have this huge kind of surgery. You have to manage the aortic valve. We have heard something about that. This is sometimes very time-consuming, so you have to think what to do in the aortic root if you want to do a complete repair of the aortic arch. And there's some risk of spinal cord injury, and I think this is something which is usually underestimated. And most important thing, think about the comorbidity of the patient. Usually what we have is not a young patient, so we have them and they have really high amount of comorbidity. So then you can start with your surgical strategy, and you can go with a single stage approach. You can do a conventional elephant trunk procedure, a hybrid surgical and endovascular technique, or something what we have seen now, the aortic debranching and stenting, and there are multiple variations and combinations of all these techniques. Let me just briefly say something about the single-stage approach. It is a real operation. You can do a clamshell incision, as you see here on the left side, or a median sternotomy in combination with a lateral thoracotomy, or even a thoraco-abdominal incision. Let's have a short look on the data which are available for the single-stage approach, and you will realize that there are 242 patients overall operated as a single approach for extensive aortic aneurysm. The in-hospital mortality is excellent, 7.9%, the stroke rate 2.9%, spinal cord injury 3%, but the pulmonary complication rate is pretty high due to prolonged respiratory support. So we can conclude these are excellent results, but in selected patients, this is actually my opinion, and in experienced high-volume centers, as you can see here, Dr. Kouchoukos, he had numbers between 50 and 70. So what about the conventional elephant trunk? And this was the topic of my talk. And here on the left side, you can see the conventional elephant trunk with a modification already done by Dr. Swenson. And we all know how this works. You do a median sternotomy, you have a graft free-floating in the descending order, and then during a second operation, you go open the aneurysm, you grab the prosthesis, and then you can suture another prosthesis down there and down to the desired level. So why is that a good idea to do a conventional elephant trunk procedure? And I just want to remind you about the anatomy. You don't have to do extensive dissections on the distal anastomosis in the second stage. And for that reason, you don't have to worry too much about the esophagus, the vagus nerve, the recurrent laryngeal, or the pulmonary artery. Secondly, you can do a rapid graft-to-graft anastomosis, which is not very time-consuming, and you don't need to clamp the native aorta, which is potentially sick. And then they came up with a number of modifications. They were anatomical or extra-anatomical. We have seen some of them before, and there are dozens of different ways how to do that. I just brought a few for you because I think this, from Dr. Swenson, this is a very smart idea to do the anastomosis between the left subclavian and the left carotid artery, because you realize that there is some tension on the distal arch if this is really has a high diameter. Or let's say here by Dr. Toda, which is some kind of a debranching procedure, and Dr. Spielvogel published in 2005 different ways how to approach the arch with a trifurcated graft. I think this is something interesting for the future, and we start to do that too. We use coupling devices that makes it probably easier to do a complete arch repair. So the idea of Shen was published in 2011 to use stent grafts as people do in the abdominal aorta is, I think, a smart one, and it will spare some time during your arch operation. What you can see here down on the right side was my former boss. He developed here this coupling device, which he used in the animal lab, which has not found the way in the clinical situation. And then the elephant trunk concept went down in the descending or thoracoabdominal aorta. Here, as you can see, published by Dr. Gozzelli, 2005, a very elegant technique, the reversed elephant trunk. These were patients who were treated first on the descending or thoracoabdominal aorta and secondarily treated on the arch, or including the ascending aorta, or the way of a bidirectional elephant trunk as published by Dr. Carell. These are now a series of conventional elephant trunk techniques, and these are 20 years, and over 20 years there were 1,500 patients who had a stage 1 repair. Interestingly, only 46% had a stage 2 repair, and the in-hospital mortality was 10% was not that bad. But what was interesting that the number or the interval mortality was pretty high in these three series, something between 12 and 22%. So people started to think about an alternative, and was getting more experience with endovascular stent grafts in thoracic aorta. They developed the so-called frozen elephant trunk. This was the first frozen elephant trunk what we had in Hanover at that time. It was a homemade elephant trunk, and the introduction system was not really the best one what we have, what you see here in the middle. So we designed a new instrument to get the elephant trunk down and descending aorta, the stented part, which was not perfect either. So we did at this time, and this was mostly the work of Professor Kark, 39 patients. Mortality rate was not that bad, it was 13%, but it was quite an extensive operation, as you can see here on the bypass times. On the HCA time was 70 minutes and selective antegrade perfusion time of 60 minutes, which was very important in these cases, because if you have an HCA of 70 minutes, you definitely need some adjunctive. But good news, 23 of 25 had a complete thrombus formation around the descending part of the prosthesis. And then people came up with different other homemade devices, as here seen by Shimamura, and they all look more or less like the same, like made in the kitchen at home. And this is one which is available in Europe. On the left side, you see the JOTEC prosthesis, and on the right side, the new vascular branch prosthesis, which is a nice one we have used in Hanover, which will be available hopefully in September this year commercially. Again, as you have seen for the conventional elephant trunk, some case series for the frozen elephant trunk, and interestingly is you can see in 9 years you have almost 1,200 patients included. The in-hospital mortality with 6.5% was, I think, excellent. Stroke at 5.4%. Interestingly, almost 60% were operated for acute or chronic dissection, and we all know that dissection is a special challenge for all of us. What was the idea? And this is the same idea like in the conventional situation. It was an exclusion of the false lumen, a depressurization of the downstream aorta. We want to obliterate the false lumen, and we hoped about the shrinking of the false lumen, as you can see here on the right side. Here, this is a very nice picture. You see after 10 days after the operation, you see 3 months, 2 years, and there's more or less no thrombus anymore. But there are also problems with this procedure. As we all know, there are aortic reentries and there are endoleaks. And it is important to mention that people have to be under very good surveillance when you do these operations. What about the endoleaks? A little bit more in detail, what you can see here, it's 6%, but there is a broad variation between 1 and 14% of endoleaks, and this may depend on the frozen elephant trunk, if it is a commercially one, self-made, or what kind of device people used and how they introduced them. So this is, I think, a very interesting multi-center experience. It was published by my friend Dr. Pacini, and this comes from the International EVITA Open Registry. 90 of 240 patients who were included in the registry were included for chronic type aortic dissection. You see 70% were reoperated, mortality 12%, and I think a substantial spinal cord injury rate of 9%. So the 4-year survival was not too bad, was 80%, and they reached, in chronic type A dissections, 80% thrombosis of the false lumen, and they mentioned that there was no correlation with spinal cord ischemia. And then there's more recently a very interesting paper. It's ahead of publication. They will publish in one of the next journals. It is from a German group from Aachen, around Dr. Autschbach, and he had 32 patients with acute type aortic dissections. He has chosen a distal landing zone between T10 and 12, so he went really far down the aorta. He didn't use any kind of CSF drainage. He had just deep hypothermic circulatory arrest, no adjunctives, and no mortality, no spinal cord injury. And what was also interesting, he had used for the sizing the whole descending aorta, not the true lumen itself, but the whole descending aorta. So it's kind of a little oversizing. It's always a discussion, how should we size the aorta and what size of the device should be used. Here again, some data for the spinal cord injury, and what you can appreciate here is the number is only 5%, which is, I think, not too bad. But again, you have something between 0 and 24%, depending on the series. What are spinal cord injury risk factors? And people try to analyze that. This is not a perfect analysis, I have to confess, but it gives maybe some ideas. The age more than 75 years, I think this could be true. Also, the previous history of aortic abdominal surgery, we all know that. A landing zone below T7, the presence of a fusiform aneurysm, the long elephant trunks, something we always discuss. And there's something we have no idea. This was a series with HCA less than 25 degrees, in addition with selective antegrade cerebral perfusion, had a worse outcome. This is against that what we discussed with Dr. Grebe, and I have no explanation for that actually. In my opinion, there are a few key things to think about. One is the CSF drainage, which should be used in these patients. We should maintain a high perfusion pressure and try to have stable hemodynamics. The question, should we perfuse the left subclavian artery? I think sometimes this may be a good idea. And we always need sufficient oxygen carrying capacity. So we end now with some open questions. Is there a progress of the treatment of extended aortic aneurysms? And Dr. Schepens asked in his editorial comment, will the elephant trunk really become frozen? And I tell you the truth, I have no idea. And I can't answer it, but my feeling is that we will use more and more frozen elephant trunks, as we do in Hanover and now in Munich. And with gaining more experience, we will figure out if this is maybe the easier way to do. So important is in the decision-making process to look at the extent of the pathology, to look at your patient, how is the condition, the amount of comorbidity. Is it a Marfan syndrome, for example? And recall your surgical ability and skills. And you need a good organ protection concept and technique, as well as some endovascular experience. So putting all that together, we can conclude that tailoring the operation based upon a patient's individual needs and anatomical considerations is important, even crucial. The interval mortality between stage 1 and 2 has to be kept in mind, independent whether the trunk is conventional or frozen, so you have to take care of your patients even after the first operation. Third, the frozen elephant trunk is often not a single-stage procedure, even if everybody telling us that it is just a single procedure. The endovascular approaches for stage 2 may avoid second major surgery. I think we have the tools to do that. The landing zone in a frozen elephant trunk may be safer compared to the free-floating conventional one with less embolic problems. The frozen elephant trunk in chronic aortic dissection may reduce reoperations by causing thrombosis of the false lumen. This has been shown in the study. But ischemic spinal cord injury remains a concerning complication. A careful evaluation of the thoracoabdominal aorta is required if visceral arteries arise from the false lumen, because if we close them, we can get into trouble. And the improved surgical techniques and end organ protection with general better outcome in the treatment of acute type aortic dissection patients may allow a more frequent use of the frozen elephant trunk. And I started with a few animals, and I want to close with them too. And you see on the left side the one here with the fresh, and on the right side the one with the frozen trunk. Thank you very much for your attention.